The committee can now go into public session. Apologies have been received from Deputy Stephen Donnelly and Deputy Alan Kelly. This meeting has been convened to consider the supplementary estimate for Vote 38 Health. So in that regard, I'd like to welcome Minister Jim Daly, Minister for State with special responsibility for mental health and older people, and from the Department of Health, and his officials. I would also like to thank you for your briefing material, which has been circulated to the members of the committee. So, Minister, without further ado, I'd like you to make your opening statement. Thank you.
Okay, Margaret Cahirlock and Bold and Krishta Kumar. I would like to thank the Select Committee for the opportunity to bring the supplementary estimate for Vote 38 before you. The total additional funding I am seeking for 2018 is €655 million. Of this, €10 million to compensate for shortfall in appropriation and aid, €20 million is towards capital works and €625 million is towards overspends and current expenditure in various areas of the HSE. I acknowledge that the amount sought is significant, representing, as it does, 4% of the overall health expenditure in 2018. This year, the anticipated level of overspend by the HSE is linked to the HSE's first charge in 2018, arising from the 2017 deficit, a shortfall in income, winter planning, growth in 2018 activity beyond plan, including primary care reimbursement service, and additional funding required in the State Claims Agency. Health funding remains a major challenge. Demographic pressures, including rising chronic diseases and an ageing population, mean that we face challenges into the future. We are implementing our strategic responses to these challenges while continuing to focus on effective management of resources to ensure that services are delivered in line with the National Service Plan. Ensuring the health service is financially sustainable is a key strategic goal of Sláintecare. The significant increases in the health vote in recent years reflects the Government's commitment to improve access to health and social services for the people of Ireland through investment across community and hospital services. We need to keep the recovery going and the economy strong so that we can continue to develop our health infrastructure and the provision of health services into the future. Next year, the Health Service Executive's National Service Plan will be framed through the lens of the Sláintecare implementation strategy. The strategy provides a framework within which a system-wide reform programme for the health service will be advanced and focuses on establishing the building blocks for a significant shift in the way in which health services are delivered in Ireland. I will now set out the items making up this year's supplementary estimate. 2017 first charge of €90 million. The HSE's recorded deficit for 2017 is €139 million. Under the Health Service Executive Financial Matters Act, any excess expenditure must be charged to the income and expenditure account the following year, and is effectively a first charge on the following year's budget. My department and the HSE completed a comprehensive review of the anticipated outturn for 2018 and identified a number of one-off savings that will be allocated against the 2017 first charge, with the balance of the funding requirement being met from the supplementary estimate. There has been a significant reduction in the level of private patient income from public hospitals in 2018. Health insurers, as members will be aware, commenced a campaign in 2017 aimed at discouraging members from using their private health insurance to avail of private inpatient services when they are admitted via an emergency department, and said they have encouraged their members to consider being treated as a public patient, as is their right provided for under the Health Act 1970. This inevitably is leading to a drop in income as more patients are opting to be treated publicly rather than privately. The allocation for the winter plan of €10 million, the supplementary allows for the commencement of a range of measures aimed at alleviating pressure on the acute hospital system during the busy winter period. Timely discharge of patients is vital to ensuring that a ready supply of beds is available to those patients requiring to be admitted through emergency departments. Delayed discharges are a major contributory factor to the emergency department's overcrowding and adversely affect patient flow throughout the hospital. It is essential that, insofar as possible, egress meets demand, and that hospital and CHO processes support timely and safe discharge. Integrated hospital and community plans are to be the cornerstone of the 2018-19 winter plan, with 9 key sites of concern selected by previous winter performance. Enhanced measures across acute primary and social care will focus on the 9 sites' critical demand pressures during a 4-week focus period to run from the 17th of December 18 to the 13th of January 19. The non-achievement of savings targets of €150 million, the Value Improvement Programme, included in the National Service Plan as a single overarching programme with 3 broad priority themes: improving value within existing services, improving value within non-direct services, and strategic value improvement. It is anticipated that none of the targeted savings under the strategic value improvement will be achieved at year-end. Acute hospitals are run at an expenditure level from 2017 which is over their approved funding level. This level of expenditure was to be matched to the approved level of funding through achieving the savings attributable to the service level and corporate value programmes embedded in the division's hospital budgets. The forecasted underachievement of targets under the corporate value programme by year-end is contributing significantly to the estimated overspend. Increasing bed capacity in public acute hospitals continues to be a priority in terms of addressing the causes and challenges of emergency department overcrowding. My department is undertaking a health service capacity review in line with the Programme for Partnership Government commitment, the findings of which are due to be published shortly. In the meantime, however, there continues to be an urgent need for capacity in acute hospitals. On that basis, it is proposed to allocate €5.7 million to acute hospitals to address critical bed capacity deficits in 2018. Community Services incorporates the delivery of primary care, mental health, disability and older persons' health and social care services. The main drivers of the overall deficit in community services include emergency placements for people with disabilities, costs associated with HICWA compliance and costs associated with Storm Emma. Support Services incorporates a number of central corporate services including finance, health business services, legal, communications, health system reform, Chief Information Officer and the Office of the Director General. Expenditure in the area is running ahead of plan for a number of reasons, including the case of a number of large legal cases, professional service costs for the Programme for Health Service Improvement and rising software and professional fees related to support of acute hospital initiatives such as maternity and newborn electronic records. In 2018, there has been a significant increase in the amount of payments made under the treatment abroad and cross-border healthcare schemes. With the trend continuing upwards throughout the year, there is a need for supplementary funding to address this area of growing demand. The increasing costs of the clinical indemnity scheme are not due exclusively to the increasing number of claims, but rather the increasing costs of awards and the very high costs associated with catastrophic injury claims. In 2017, significant progress was made on legislation which is expected over time to lead to a reduction in costs. From a health perspective, the most important aspect is the provision for periodic payment orders. Courts will now have the power to award damages by way of periodic payment orders where appropriate, have regard to the best interests of the plaintiff and all the circumstances of the case. In addition, with the enactment of the Mediation Act in October 2017, which provides a wide-ranging statutory framework to promote the resolution of disputes through mediation as an alternative to court proceedings and to reduce the stress for parents and families which often accompanies court proceedings. It is hoped that more families will opt for this route. €46 million is sought towards the projected deficit in 2018 in the State Claims Agency. Funding will be provided for a number of GP fees and allowances, including €4.8 million towards the cost of providing free cervical check consultations. The greater than budgeted number of medical cards is driving an increase in the number of items dispensed, and it is proposed to allocate €3 million to cover this increased cost. It is proposed to allocate €30 million to cover the continuing increase in high-tech drug costs for treating conditions such as rheumatology, cancer and cystic fibrosis. €7 million will be allocated to cover the cost of treating long-term illnesses, the most prevalent being diabetes and epilepsy. Appropriations in aid are received by Ireland from the UK in respect of health services provided under EU regulations. The amounts received are based on the Ireland-United Kingdom healthcare reimbursement arrangement. Costs associated with UK pensioners residing in Ireland account for the major portion of the total payment. Historically, each country's pensioner liability was agreed based on the results of sample pensioner surveys undertaken every few years. More recently, both administrations have agreed in principle to work towards the introduction of a revised methodology for determining pensioner liability. Trends in demography and migration between the two countries would indicate a reduction in the number of pensioners for whom the UK is liable. Initial discussions with the UK had indicated that receipts in 2018 might be in the region of €225 million against a provision of €280, a difference of €55 million. Detailed discussions, however, have recently finalised and a total payment in 2018 of €270 million has been agreed, leaving only a difference of €10 million there. There is an ambitious programme of capital investment in health reflecting priority accorded to capital spending in the programme for government position that health capital spending would be a priority. The priority government projects, most of which are either underway or about to commence, account for a substantial proportion of the health capital allocation in 2018 and the coming years, resulting in a high level of commitments. During 2018, extensive measures to actively manage the capital budget have been applied. This has involved balancing as much as practicable the fulfilment of contractual commitments, delivery of projects and managing equipment and infrastructural risk issues, such that capital expenditure remains within profile. Following this extensive engagement and management of issues, capital spending in 2018 remains within profile. The HSE has informed the Department that the provision of an additional €20 million in 2018 and the management of the project's budgets there will be no overrun in 2018 capital funding. A significant increase in funding for the health services has been achieved in recent years. As I have stated previously, the issue of health funding is a major challenge, not just in Ireland but internationally. Dealing with a growing and ageing population, more acute health and social care requirements, increased demand for new and existing drugs and the rising cost of health technology will continue to pose a financial challenge into the future. Sláintecare gives us a new roadmap to support the delivery of high-quality care to our citizens, improving the way services are organised and delivered and reducing costs in order to maximise the ability of the health service to respond to growing needs must remain our focus. It is essential that those managing and delivering the service continue to demonstrate good practice by delivering the best possible healthcare within the significant level of resources that have been made available by Government for 2019. This additional funding in 2018, combined with the 2019 budget provision, is a practical example of this government's commitment to use our economic growth to restore much-needed funding to our health service. The above item, together with cash projections to year-end, involve an exchequer requirement of €655 million. In conclusion, Cathaoirleach, I seek the committee's approval to the supplementary estimate for vote 38.
Thank you, Minister Daly. So, Deputy O'Reilly, are you ready to?
I am indeed, and I'm
start?
sorry that I wasn't here for the start. I could say that I was caught in traffic, but I was actually getting a coffee, so I might as well be honest. Yes, no, honesty is the best policy. Minister, you're very welcome, and thank you for coming here. We have in the past previously made comment on the fact that the Minister himself is not available, but in the circumstances and given the lateness of the time that we adjourned last night, I'm not going to go down that road this morning, but we do thank you for being here and for outlining the supplementary estimates to us. So I have a couple of questions, if you don't mind, and I'll run through them and maybe come back to them all at once, if that's okay. Yeah, okay. So on page 5, we have been, of the briefing note, we've been given a rough breakdown of the €529 million and how that's spent. I'm looking for a more definitive breakdown, specifically of the €220 million that's spent in acute hospitals. How much of this, can you tell me, was spent on agency staff? Again, pages 5 and 6, the focus is on the €346 million in savings to be achieved. Now, I've questioned people from the HSE about this previously. Where did that figure for €346 million come from? There must have been some sort of formula used. There must have been some sort of calculation that was used. How was it calculated? And, you know, what research went into it? How did you get to that conclusion? I mean, it was unrealistic. It wasn't reached, and it was missed by quite a long shot. So it strikes me that whatever planning went into it wasn't sufficient. But I'm also curious to know, and the HSE couldn't give me a definitive answer to this either. Where did that figure come from? I mean, you know, we all heard the tapes of the fellas telling us where they got the figures in relation to banking. I sincerely hope it didn't come from there. But can you give us some sort of an indication as to how you arrived at that figure? So, the Fiscal Advisory Council have told us that overruns in health have averaged 0.5 billion per year in current spending terms in 2018, and that the overrun would be 0.6 billion. So, is it not then the case that the health service is actually underfunded to the tune of approximately 0.5 billion since 2014? And I think that we can't keep having overruns and supplementaries and overruns and supplementaries and then somehow get to the end of the year and say, well, actually, you know, we're not being underfunded. I mean, you know, you don't need to be a mathematical genius to figure out if we keep overrunning, well, then we are being underfunded. Also, with reference to the Fiscal Advisory Council, they have stated that health budgets should be well-founded and credible. They've also said that weak planning and weak spending controls account for the genesis of many of the problems. So, in relation to spending €234 million so far this year, that's €866,792 a day on agency staff. I'd be interested to know how that fits into a well-founded and/or credible budget. Similarly, the Fiscal Advisory Council have stated that the health overruns are being masked by unexpected corporation tax and interest. The Council also states that as the top 10 companies account for roughly 40% of all corporation tax receipts, unexpected revenue from this source should be deemed as transient. So you can't rely on it, but it seems that we do rely on it. With that in mind, I'd be interested to know what the Department has to say in relation to their own responsibility and their own duty to fund health in a responsible way, because that, you know, if this was how you were running your house and balancing your budget, you'd probably find yourself down in MABS on more than one occasion trying to figure out how it works, because this is no way to run a household budget, never mind a massive budget for a high spending department. Last year, Immediately following the budget, I said, and I wasn't the only one that said it, that not enough was being given to the health service, even to fund standing still. So just to meet current service level, and we could debate all day about how inadequate the current service level is, but just to do that, there wasn't enough money being put into it. Weeks later, Tony O'Brien, who was the head of the HSE at that stage, wrote to the Minister outlining that he believed that the HSE was being underfunded for 2018 to the tune of hundreds of millions. And this is exactly what happened. So we see that. And I mean, I'm no fortune teller. Clearly, if I was, I'd pick the lotto numbers and I may not be here. But I could see it. I pointed it out. A couple of months later, it was pointed out by Tony O'Brien. So at what stage was the department in the year, was the department aware that the health service was being underfunded? Because I'm sure you're not just going to take my word for it, but Tony O'Brien had written to the department, and it strikes me as odd that he would have to write that letter and that the powers that be would not be fully across the situation and aware that that there was going to be that underfunding. And as I say, I wasn't the only person that pointed it out. But I did so, and I was dismissed, I can tell you, and I was right. and it gives me, I'm not going to say it gives me no pleasure to say that, because we all love to be right, but it just strikes me that if I could see it, and Tony O'Brien was flagging it, at what stage were you guys actually aware of it? Because that, I think, is material to how we keep finding ourselves in the same situation at the end of the year, every year. Okay. Thank you, Chair.
Thank you, Deputy O'Reilly. Minister.
Thank you, Cathaoirleach, and thank you, Deputy. And I suppose, a number of issues, and they're all kind of broader ones. I don't know, do we have a figure for agency staff or not? But I might get it to you at some stage. Okay, you asked a very direct question about how much we are still spending. I know there has been some conversion this year on that, but I see, can I get that figure for you exactly? You make a very valid point about the savings, the 146 million. How was it calculated? Where was the estimate? Because I mean, what I'm clearly saying here today is that the HSE did not achieve the targets set for them in trying to reach savings across the three VIPs, value improvement areas that were identified. So what was wrong? Is it the HSE's inability to achieve the targets, or is it the targets that were set were unachievable? That's the question I think you're asking, Deputy, that you're trying to get.
I'm specifically trying to ask how that figure was arrived at.
Right.
Okay, because the HSE didn't reach it. Mm-hmm. But it has to have been based on something. I mean, like it
wasn't plucked out of the sky.
It wasn't. Yeah. It was the sky or anywhere else. So it's just there must have been targets. There must have been someone sitting there going 300, because otherwise it would have gone 350 million. I mean, if they were just, if you wouldn't say 346 unless, and this is me being very cynical, somebody said, well, sure, let's put 350 million in, and someone else said, well, no, let's make it 346. That sounds more credible.
More accurate, yeah. We're doing something.
So it has to have come from somewhere.
Okay, and I'm aware this question was asked, I think, at the last two committees, and you still haven't got an answer to it.
I really haven't.
Yeah. Okay. Well, the answer I'll give you is that I will undertake to try to assist you get an answer to that. I don't have the answer here to either where that figure came from, Deputy, but I will go back and ask the HSE, would they please provide me with the answer, and I'll certainly copy you in on that answer.
Just on that, Minister, the HSE themselves appeared to put a bit of distance between themselves and that decision.
Okay.
So it's a little bit they and this is from memory now, and I'm not reading back any transcripts, but my memory of it is that they sort of said, well, we were given this target, but somebody should have been sitting down with them to find out, one, is it realistic, which we clearly know it wasn't, and two, where are you going to find it? Because you can't just hand them and say, there's your savings targets, but we haven't figured out how we're going to help you to, or if they're realistic at all.
Yeah, your question is very valid, and I can accept the premise of your question of wanting to know the origins of this figure and where the basis for it came and how it was calculated. Somebody must have seen it as an achievable target based on some sums, and that's what you want to know, is what were the sums that were done or the calculations that were done that generated this particular figure. So I'm trying to get to the bottom of that for you. I suppose, look, just on the wider issue of trying to achieve savings, and it ties into your next question about, is the HSE funded sufficiently? I suppose there is the constant ebb and flow, and there is a tension there all the time, as well as the swings and highs and lows of the roundabouts of the economics, highs and lows. There also is the ebb and flow and the tension that is necessary. If you give the HSE so much money, if you give them another €1 billion, another €2 billion, should they spend it anyway? So you have to kind of try and push back and keep it as tight as you can, and probably underfund them insofar as you can to a point, because there is no absolute. It's a demand-led service, which is important to remember. So nobody can.
It's created by sick people.
Yes, yeah, but it is a demand-led service. So I mean, nobody can. You said yourself you don't have the powers of fortune telling, and nobody on the other side of the house has those powers either to accurately predict how many people will present at A&E, how many people will present in primary care, how many people will require surgery, you know, and so on and so forth. What new drugs will become available in any given year on the market, how many people will require those drugs, you know, what value for money will be or what price will be agreed. So there's a lot of unknowns and a lot of variables in a year-to-year basis in any health budget. This isn't unique to Ireland, and of course the demand-led aspect of it makes it very, very difficult to quantify. And you know, that is something I think that may not be told as well as some of the other stories in the health service, is the significant increase that has taken place in the amount of activity within the health service in recent years. There's a very, very significant amount of procedures have taken place, significant amount of day case and hospital admissions. There's a significant, I could tell it in my own area of CAMS, for example, in child and adolescent mental health services. You know, there's 26,000 people now being seen by CAMS in a year. It's a very significant increase in the number of people being seen. There still is increases in the number of people being waiting, but the full story has to be told as well by pointing to the increases in procedures. And that's where we get the real picture. It's a little bit like, and I'm sure it'll come up again in a minute, is the whole issue of trolleys. And I feel very strongly that the focus on trolleys is so misguided. It's so easy for us as politicians and for our colleagues and friends in the media to obsess about trolleys and trolley gar and those figures that they always make. But I mean, the real issue is how long people are waiting, first of all, not how many people are on trolleys, but how long you're waiting on a trolley. But more importantly, we should be focusing on the delayed discharges and the amount of people who are coming out of hospital and what's blocking people from coming out and preventing people from coming out. We have been for too long looking at how many people are blocked coming in, where the real focus should be, I think, and I personally believe, shifted to those who are delayed and have their transitional care delayed because of lacks in the system. The reliance on corporation tax, I suppose, look, that's a kind of a broader debate, and that's more for deeper than it is for the Department of Health. It just happens to be in the news again this morning that there's a large surplus increase, but I mean, it's an accepted point of knowledge, I think, within the wider system, not just the Department of Health, but the Department of Power and the government as a whole. The corporation tax can go high and low, and we've seen that on many times, and we certainly wouldn't like to be building a reliance on it, and I don't think there's a direct correlation between the funding of the HSE and the funding and the amount of corporation tax that comes in. It just happens they're both timely in the news at the moment.
Sorry, my question was, do you think that this is a responsible way to fund the health service? And the answer to that is yes. I'm quite surprised, because I don't, and the Fiscal Advisory Council don't.
Do you think which is a responsible way? What specifically is a responsible way?
Funded it from corporation tax and interest. That it's not reliable.
Well, I mean, it's not funded from corporation tax. It's funded from general taxation. It's funded from general taxation. The HSE, I mean, corporation tax makes up about 18% of our overall tax take in the country. Health is a much greater spend. I mean, health is funded from tax, period.
The Fiscal Advisory Council have said that the health overruns are being masked, and this is a quote, by unexpected corporation tax and interest. It's not me saying it.
Yeah, but that's a separate point. They are not saying, the Fiscal Advisory Council are not saying it's being funded by corporation tax. They're saying it's being masked.
The funding is being masked.
They're saying that the overruns are being masked by, because, in other words, that we have the ability to cover the overruns because of bonuses in corporation tax is the point they're making. But it is not being funded by corporation tax. It is being funded by general taxation. And your question is about our reliance on corporation tax. Are we over-reliant on corporation tax? That's a broader question. That's a question for the Department of Public Expenditure and Reform to answer. About us as a state, it's not peculiar to the Department of Health.
No, and Minister, the Fiscal Advisory Council made a specific comment about the health budget and about the overruns, and that's what we're here to discuss. Yeah. And they were very clear. And I asked you, did you think that was a responsible way to fund it? And your answer is it's not being funded that way, but it actually is. I mean, the overrun is part of the spend now.
Yes, and corporation tax is part of the funding mechanism of the health service, but so is income tax, so is VAT, so is every other taxation head and subhead is partially funding, you could argue, the overrun in health. So the point is a moot point there. I don't think it bears, it holds up to scrutiny.
The Advisory Council would differ with you on that, and
that's
they specifically
that's a very healthy attitude if the Fiscal Advisory Council take exception to anything I say. I have no problem with that.
And the overruns, and I mean, trying to pretend that the overruns are not part of the spend is nonsense. They are. They clearly are part of the spend. And if they are part of the spend and they're being funded from an unreliable source, I asked you, did you think that was responsible? I mean, if you do think it's responsible, I don't agree with you.
Okay, Deputy, and I don't think this over and back, I'm not sure, is this the usual, is it, the cross-examination? But anyway, if that's what you want to engage in, I have no problem with that.
Oh, Minister, I apologise if I came across as cross-examining. I'm trying to get a specific
I don't want to be
answer.
reinterpreted, or I don't want words to be put into my mouth that I
No,
didn't say.
I didn't try
Just
to
on
do
that
that.
point, Minister, what we do is we allow a deputy 10 minutes or so to ask questions and to get answers. So perhaps speaking over each other is not going to be very beneficial.
Yeah.
So if you could give the Minister an opportunity to
Absolutely,
answer
Chair.
and then submit another question.
Okay.
And
And just to answer specifically about the reliance on corporation tax to fund the overruns, there's many other taxations will fund the overruns, and health is the point I'm making. It's not just corporation tax, and my opinion on same is irrelevant, to be quite honest, because there's so many other tax heads contributing to it. The department approach to running a household budget, you were saying, making the point that what's the department's approach? Again, that's the point I opened with. It's a demand-led service. It is difficult to absolutely quantify, and you cannot over-give to the health service, because if you over-give to the health service, well, then the health service will overspend and overutilise. We have to make sure that there's a tension there so that we're getting value for money, and that's the same as funding any demand-led service. You have to have checks and balances to ensure it, and that's difficult. You have that then compounded with the highs and lows of economic activity. What stage, I mean, the department are obviously get updates throughout the year from the HSE. It is not at the year end that the department become aware of the overruns. They would become aware during the year of the pressures and the likely pressures, but a lot of them are projected and a lot of them are anticipated, and there's efforts made to try and avoid them. So you cannot be absolutely clear until later in the year. But I mean, the department would be engaged with the HSE from the start of the year, seeing that they're on target to meet their spending targets. I think that might have answered your question, Deputy, but if there's any other questions, feel free.
Have you one more question, Deputy?
Yes, I do indeed. You mentioned that you would have some figures for me in relation to the agency spend, and you mentioned the issue of conversion. So when we had Stephen Mulvaney from the HSE in, we asked were there specific targets set in relation to the conversion of agency staff, and it appeared that there weren't. So I'm wondering, has the department, I mean, I keep going back to the figure of the 346 million savings. So some of those obviously will be conversion from agency, which is very expensive and a very inefficient way to run the service, upon which you're becoming more reliant. Some of that I would have thought, that 346 million, but if there were no targets in place for the conversion of agency staff, and then it would seem that no attempts are being made to control that, because the HSE have said to us, oh, we do try to convert from agency, but if there's no targets being set, but then there are targets being set of 346 million for savings, can you give me some sense of, you know, out of the 220 million budget, how much of that was spent on agency, and out of the 346, how much of that was identified for conversion? And just with regard to planning and a demand-led service, Minister, we haven't had a major outbreak of disease, so there's nothing that's happening in the health service now that couldn't have been predicted by looking at the CSO. I mean, we have an ageing population, that's a good thing. People are living longer, they're healthier, and that's absolutely a good thing. But there's no major challenges that I would have seen. You mentioned the storm, that was a couple of days. There's no major outbreak of disease or anything that you couldn't have looked at the CSO figures and not been able to plan ahead for it. Thanks, Chair.
Thank you, Deputy O'Reilly.
Okay, and I don't want to disagree with the Deputy all day, but I mean, there are several factors that can't be predicted. For example, the outcome of negotiations of the current GP contract, what cost that will have. You know, that's dependent on the outcome of those negotiations. No, Deputy, if you leave me without interruption, please, just to make my point with respect. You know, there's also the negotiations with drug companies. It's a huge cost there to try and, if there's a decision taken or not to agree, you know, pay increases to you know, 32% of our staff are nurses. If there was a pay increase, a government decision taken tomorrow to give some pay increase there, the HSE wouldn't know that in advance. That would be, you know, so on. So there are several factors that cannot be just by looking at the CSO figures. It would be great if we lived in a world that we could identify 100. And of course, one of the big underlying challenges within the entire health system on this very point is the lack of an up-to-date IT infrastructure to collect data, to share data, to analyse that data. You know, our structure is really not fit for purpose when it comes to that kind of planning that the Deputy is talking, and I think she would agree, we probably would both agree on that. The second question, on the agency staff, I will ask, I'm not the financial officer within the HSE, but I will ask the financial officer within the HSE to give me a report on the agency staff, and I will particularly ask him to address the question that you've asked about targets, of what their targets for conversion are and how many they achieved, and I suspect they won't have it from me until the year end, you know, that we can get a year end of 2018, but I will ask specifically for that to be given to the Deputy early in the new year, based on the year end figures of conversion particularly.
Thank you, Minister. Now, Deputy Margaret Murphy.
Thank you, Chair. I'd like to welcome my constituency colleague, Minister Daly, in here. And
holding the forts down all on our own.
Always are. And I have it for 10 minutes now, so.
Children are represented as well. Come on now.
I suppose, first of all, I would just like to thank you for bringing Minister Harris to West Cork on Monday, and to very much welcome his announcements. And I suppose just I'd like to work with you to make sure that what you said would happen will happen. So just want to put that on the record. Minister, you started there by saying that health funding remains a major challenge, and I do appreciate that, but there does seem to be a major lack of planning, especially with regard to winter cover, I suppose, for the want of a better word. Like it's quite obvious that things will happen in the winter, and the winter isn't just December anymore and isn't just Christmas. So I just find it hard to get my head around why year after year, this is my third winter here, and it's, you know, that it just don't seem to be able to get your act together with respect, you know. So I just maybe just comment on that. And in any place, I suppose, if you're looking for more money, you need to ensure that you get value for that money. And with regard to the delayed discharges, obviously a major problem, but it's, I suppose, the reason why there's nowhere for them to go is something that needs to be looked at as well. Lack of step-down beds and home care packages. So I think that's just the delayed discharges are, you know, just the top of the cake, really. I think we need to dig into it a bit more. With regard to the acute hospitals, they're over their approved funding level. I just maybe like you to expand more why this has happened, please. And with regard to community service, particularly mental health, I'm still waiting, Minister, for an answer to the question with regard to Bantry, to the psychiatric unit there.
You never got an answer from
no,
the last committee meeting?
No. Okay. And I have tried again with a PQ, and so I suppose just the number of staff there, the lack of consultation rooms, and if there is a dietitian available. With regard to the cross-border healthcare, I think it's very important to put out there that the HSE still have to pay. There's a myth there that this service is magic and it's free, or else that maybe Great Britain's health service is paying for it. So I just want to put it out there that we do end up paying for that, but I'd just like your comment on maybe why it is necessary that people think they have to go up to the north when we end up paying for it anyway. Why not? Why not do it here and make it more comfortable for people, especially from West Cork, who would find it hard to make the journey? With regard to the primary care reimbursement scheme, GPs, just a comment on whether, you know, staffing levels have been increased, and with regard, I suppose, to the big cervical check, you know, there's people still waiting very long periods, especially if their first test comes back as unclear. They've, you know, in our constituency, I know of a few people who've actually had to wait in total 8 months because of an unclear result. So it's, I suppose I'd like your comment on that. I'd say that's about it now, and not too bad.
Thank you very much, Deputy Murphy. Now, Minister.
Okay. Thank you, Deputy, and thank you very much for your comments regarding the visit of Mr Harris to the constituency, and and the investments that are coming to the constituency, and your support of those initiatives is very much appreciated as well, and continues to be, and I will continue to acknowledge that as well at any opportunity I get. Just regarding winter planning, and in your own words, to get our act together, whatever, yeah. The winter planning initiative, I mean, it is a fair question, why is there a need for an initiative for a winter plan? Because, you know, there's a winter in every year and there's a summer every year, and, you know, they're predicted, as previous conversations were saying. We know the weather is going to be bad, we know there's going to be increased pressures or whatever, but yeah, and every year it is an annual event, the winter is an annual event, is your point. So if you have a winter plan, maybe you should have a summer plan and you should have an autumn plan, I think is you know, and look,
anyway, yeah.
and on an academic point, that's a fair point and that's a fair comment. That why is it necessary? Notwithstanding that, I suppose there's a unique set of challenges then that present, and I suppose there is an onus on the Health Service Executive to be prepared, because the peaks and troughs can be particularly acute at the winter time, more than, you know, the challenges can become really, really exacerbated at a period of time.
Surely you know that, though, you know, so what... You do
indeed. You know that you're going to have a winter, you know, but you don't know the extent of it or the level of it. I mean, if you have a major outbreak of flu epidemic, and if you had a storm, and if you had a combination of, you know, the timing and whatever, if there was a whole series of things that could come together, they may not come together, all in that 3 or 4 week period, well, then you would have, you know, particularly catastrophic implications and impact on people who need to access the services. And I suppose a bit of forward planning and a bit of proactive planning year on year. Things have changed. The weather patterns are changing every year. You know, the weather pattern isn't the same as it was 5 years ago. So if we were using the same plan...
It's consistent, though. It's consistently bad the last few winters, the weather, like...
Yeah,
so.
but we've had severe, you know, like the storm Iman, we've had the snowstorm, you know, which we haven't had any the years previous, you know, which actually, you know, brought staff to a standstill as well, and something now in very minimal cases, I must add, staff made an incredible effort to get to work, as you would be aware as well, Deputy, during that period. So, but the point I'm making with, and I agree with you and I accept the point you're making, but I'm also, I suppose, looking at the other side of it, where, you know, there has to be contingency plans for particularly extreme events. And they can never be quantified exactly year on year, because they can change from year to year based on particularly outbreaks of flu or whatever. So I mean, like things like, you know, very simple basic things like the flu vaccine for healthcare staff. There's been a particular effort again this year, but we cannot stress enough the importance of staff, all healthcare staff, whether you're working, you know, in behind the desk, or whether you're administering medicines, or whether you're cooking foods, or whether you're in there playing the banjo a night a week. It is really important that people who visit healthcare facilities have the flu vaccine, and we cannot stress it enough. I was somewhere, I think it was in New York recently, and they told me that over there, if you have not had the vaccine, the flu vaccine, as a healthcare staff member, you have to wear a mask. You have to wear a mask.
Free, Minister?
They are to staff,
so
yeah.
all medical staff get a free?
They are,
okay,
yeah.
But not compulsory?
Yeah, they're not compulsory. No, they're not compulsory.
We've
looked at many ways of trying to incentivise, because like flu epidemic is massive, and particularly for older people who are very, very vulnerable in healthcare settings, whether they're acute hospitals or nursing homes. An outbreak of flu can just devastate, and I mean, you could end up sending, one nursing home could end up sending 10 of its residents into an A&E. Yeah. At the height of the Christmas period, you know, at the height of bad weather or whatever, you know, so these things, there's a lot more, so that's why winter planning is so important on so many levels, and it does give you an opportunity to reiterate some of the key messages, and that, if anything, we could get out a bit more would be the flu vaccine. They call it about herd, the doctor would know, the chairman would know an awful lot more about herd immunity, that the more people who have the vaccine, you can actually eliminate the possibility of the flu taking hold or catching anybody in your care. So it isn't just enough for the people themselves to have the vaccine, but it's those coming in contact with them to have it as well. So, you know, these are things that come out of winter planning. Obviously, value for money you talked about there, look, that's a continual, and I think we will agree both on that, Deputy, that value for money has to be to the core of what we do, and that's why we can't just say to the Health Service, take 20 billion next year and all your needs will be met. There's no incentive there then to get value for money, so that's why we have that ebb and flow. Delayed discharges, home health packages and step-down care, you're absolutely right, that if we could get more and more home care packages, and as you know, we announced 550 intensive home care packages, which are very separate to just somebody getting an hour home help in the morning and an hour home help in the evening. You know, an intensive home care package is the same as really facilitating somebody to leave hospital. But I couldn't agree with you more. It goes back to the point I made earlier. We have had all the focus as politicians and as media and as narrative on trolleys and counting trolleys twice and 3 times a day, and the INMO do it and the HSE do it, and I'd say the amount of money and time and effort and everything else that's wasted, quite frankly, on counting trolleys just because it's an easy figure to kind of give. It is far more important, you know this, Deputy, as a practising politician, and I know it as a practising politician, that if one of our loved ones went into A&E in the morning and if they're in a trolley for 2 hours while waiting to get a bed upstairs, you know what? There's nothing wrong with that. We would have no difficulty. Trolleys aren't the most uncomfortable place in the world to be, provided there's a bit of dignity around it. And comfort, they're very expensive pieces of equipment, actually, trolleys. They're extremely expensive. But anyway, that's neither here nor there. Whereas if some of our loved ones was 19 hours on a trolley. Now, there would be something wrong if there was 20 empty beds above in CUH, and if you and I presented in the morning and could go into any one of them. You know, the hospital should be operating at capacity within reason. So, you know, 2 hours on a trolley shouldn't really be counting for anybody. But anybody that has more than 2 or 3 hours on a trolley, well, then you're starting. So it's the length of time people on trolleys is far more important if we were to talk about trolleys. But I would argue that trolleys are still missing the point. We should actually put our focus, we should be doing a count on the number of people inside our hospitals every day of the week who shouldn't be there. Because it is the most dangerous place for somebody who's vulnerable, who's older, to be a day longer in an acute hospital than they absolutely need to be, you know, isn't where they should be. And that's where our focus should be if we were to really challenge this. And we're all a bit responsible for that by allowing the narrative, particularly the media and politicians, of the trolleys becoming an obsession of people that are not willing to look at it a bit further.
Are there some other questions, Deputy, that haven't been answered? No?
No.
Okay.
Oh, can I apologise on the Bantry Hospital issue, Chair? I take exception to that the Deputy didn't get any information. I did ask for that information to be sent to the Deputy after the last committee meeting here, and I undertook to do it, so I apologise unreservedly that you haven't got that, and I will be following up that with some
Thank you very much. Deputy Durkan.
Thank you, Chairman. My apologies for being a late entrant. It was due to multiple issues this morning. Welcome the Minister and his officials here. Just a quick one. In relation to the income shortfall that was under discussion when I came into the room, there are a number of reasons, of course, for that, and the unpredictability of it I can understand readily. However, if one looks at, for instance, the last 4 or 5 years, one can identify a particular trend or a source. And to what extent has that been done? In other words, is the same issue coming up again and again and again and again? And if it is, how can we get to it? Because it does create a problem and it creates an unease within the system, particularly for patients who have to have access to the system, whatever the case may be. I know that the public hospital versus the private hospital and the insurance shift over and the insurance. I'm getting a little bit concerned about that, and maybe the Minister might be able to tell us a little bit more about it. You know, the reference is made that the public hospital receives a fee of €80 per night up to a maximum of 800. But this can drag on and can become a bigger figure as time goes on, and can alleviate the burden on the private hospital, the private sector, to a fairly huge extent, to the extent that the public sector are effectively subsidising the private one. And you know, I have no ideological views one way or the other on this issue, but if it's creating a problem in the funding for the public hospitals, then we need to look at it, and that's why I think that maybe now is as good a time as any to once and for all deal with it. The winter plan, well, you know, we've had that before. Every winter is going to be a test of its own, of our resources. I agree with the Minister in relation to the trolley count. The trolley count is becoming misleading. That said, he rightly identified the length of time one spends in a trolley is the critical issue. Everybody hopefully will get into a trolley at some stage from the moment they get into the A&E or whatever. Otherwise they're going to be left in the ambulance or at the door or whatever the case may be. So that's the part of it. It's the speed with which the patient is dealt with after that. That's the critical issue. And I would hope that maybe we could identify that in future counts. And I know that in the past there were very, very considerable waiting periods for elderly people in trolleys, which can cause considerable distress. And maybe the Minister might be able to give us some idea as to the extent to which we are keeping a tab on that, as it were, and watching its development, its evolution, or whatever the case may be. And I might have another question in a minute, Minister. I have to get me functions together, you know. I hadn't any coffee yet.
Thank you, Deputy Durkan. Minister.
Yeah, thank you, Deputy. Yeah, you've asked there about the public and private. I mean, you are aware of the Butler report that has been done, because there's a bigger issue there. There's a wider issue of the whole use of public and private. But on this issue, just on health insurance, is where people, as you're aware, when they are admitted through A&E, they have the option to be admitted either into the public or the private, and they've been advised of same by their health insurance, private health insurance companies, to go in through the public door, and that's perfectly legal under the Healthcare Act 1970. They're entitled to do that. And you're right, then it's an €80 a night charge up to a maximum of €800 for 10 nights. Some of your other questions were I suppose you asked there. What were the other questions?
The trolley
yes,
time.
Yeah. You know, look, sure, you're kind of repeating, I suppose, the same as what I've said, accepting that it is a lack of, and you're accepting the point that we really should be much more focused on the real challenge, which is what's preventing capacity within our hospital group, while it's preventing the free movement of people in and out of hospital, and that's where the challenge is, as opposed to over-reliance on. And you make you very articulately put the point again about the length of time in a trolley, and that all of us should be damn glad to go onto a trolley when you get in there straight away, but provided you're not left waiting there, as is the case in too many cases. And you particularly say about older people, and that is a big challenge for us, because the amount of people over the age of, I think there's 1.4 million presentations to A&E in a given year. And I think the number of people that are over 65, and that would be about 50%, I think. I hope I'm right. I met with a group of consultant geriatricians recently in Cork, and I think that was the figure they gave me. So, you know, it's a big challenge for us to see that older people in particular are not left waiting unnecessarily long waits of time to access acute health care. Was there was there another question, Deputy?
Yeah, the state debt agency seems to be increasing its demand on the budget as a percentage of its demand on the budget. Can you maybe shed some light on the various issues covered? I know some of them come to mind fairly readily, but just to what extent have you and the department examined the full extent of where that's heading? Because to my mind it looks to be heading in a rather burdening direction, for want of a better description, in the sense that it's popping up again.
Yeah.
And will pop up again.
Yeah, I suppose today, and the Deputy will be aware as a keen observer of the legislative timetable, that there's two pieces of legislation of note enacted recently in October. One was where there is a legislation to, what's the word, to periodic payments, thank you, to enact periodic payments, so that these settlements, particularly these very large settlements or awards, awards that are compensation payments that are awarded in the courts, can be paid out over a period of time, you know, obviously keeping in mind the best wishes and best outcomes for the plaintiff. But that legislation was passed only in October of this year, so it would be hoped that that would steady the sharp increases that are there at the moment. It is also worth noting that it's not really a massive increase in the amount of claims. It's as much about the size of the awards. It's as much about the size of the awards that have been made in the courts for particularly catastrophic injury cases. And obviously, and you as a public representative have a separation of powers between the state and the judiciary, between us and the judiciary. So we have to be careful where we go there. But that is the matter of fact, that it is the size of the payments that is causing the increase, as opposed to the volume of them. It isn't just the volume of them. That would be too narrow a definition. There was a second piece of legislation in October as well, which was the Mediation Act. Again, I've read these briefings and tried to. Yeah, it was the Mediation Act, and the Mediation Act is an effort to bring about mediation, as opposed to going through the costly expenses of the courts, and obviously saving the personal trauma as well. And that was in October of this year as well.
Has that started to operate? Yes.
I think it was enacted in October, from what I can recall, Deputy, the Mediation Act. So I think that is in place, that people can avail of it now. So there are two significant pieces of legislation that should contribute towards this. But obviously there's the Book of Quantum and things like that, which are reviewed periodically as well, and there's issues that arise there within that as well.
Thank you very much, Minister. Minister, could I ask you a few questions myself? And I'll just ask them one at a time, so to give you an opportunity to answer. In the year 2018, can you outline to the committee what was done differently to 2017 to mitigate the overrun. The overrun in 2017 was 200 million, and the overrun in 2018 was 700 million. So what was done differently, or what failed to be achieved in 2018 in relation to 2017? Is there a change of planning? Is there a change of how you develop the health service plan, which hasn't been published yet this year, so that the overrun does not continue year on year?
Yeah, thank you, Deputy. It's a very good question. It probably gets to the heart of really the issue we're discussing today, and that's a good way of asking it. What's the difference between the planning for 2017 and the planning for 2018 and the implementation of 2017 and 2018? What was done differently? Obviously, the issues that arise can be separate. Okay, the demand is the biggest thing. You know, if you have an increase in demand, or we have an increase in demand as the ageing demographic, whatever, so there is more pressure coming onto our health services. So that is fundamentally shifting the dynamic on the overrun, because it is increasing at a faster rate than we are actually projecting for. That's the first difference, I suppose, between 2017 and 2018. Then there's individual issues that arise, as I said, the appropriations and aid, which is a complex payment arrangement we have with Britain regarding pensioners here, and guesstimating how much that will cost, and then negotiate it down and whatever. Then you have incidentals that arise in any one year that can be, I know storm and things like that are smaller scale, but they can be bigger ones that I've referred to there. Some of the headline issues that I would have said there would be the primary care, the high-tech drugs obviously would be a big one if a lot of them came on. What was the biggest headline one? Would be in 2017.
2017 was pay awards.
The pay awards would probably be the biggest. The biggest increase in demand for payment would be the pay awards. There was, as the economy recovered, they weren't there into. They're not there every year, and they're coming off the back of a recession. The appropriation aid is quite small. What are we doing about it? Like, as you say, as you know, Chairman, we're agreeing the service plan at the moment with the HSE, and there's a very, very keen focus on every aspect of that we're not in the position again in this perpetual cycle, and or that we're perpetuating that wrong again every year, that there's an overrun, So we are trying to stringently monitor expenditure with the HSE at this stage, even when we're preparing it and when we're planning it and when we're trying to agree a service plan, that it can be on target, that it can be realistic, and that it can be within. But there are events, my dear boy, events that are just always going to be unforeseen, that will take and detract a lot away from it. For example, this year we had the cervical check. That wouldn't have been just in its cost, wouldn't have been the major. There was cost runs on that, I think 4.6 million for GPs off the top of my head. Small payments like that, they're not massive in the bigger scheme of things, but it also takes away a lot of attention, and a lot of focus, and a lot of staff are moved off onto an issue like that. And that's what we want to try and be more ready for next year as well, that we have more consistent and more constant focus on the implementation of the service plan month on month, and that we're coming in on budget with a ruler month on month.
Well, the Fiscal Advisory Council would maintain that there is weak planning in the HSE and in the Department of Health to anticipate expected but also unexpected events. But there is weak planning. And then at the end of the year, there is an expectation that if the health service goes over by 700 million, that will be met. It will be carried over to the following year in the hopes that the following year the budget will actually come in on target. Yeah. But it never happens. So that comes back to weak planning. So what can be done to strengthen the planning so that you can have an accurate estimate of the cost of the health service?
Okay. It's a difficult one to get. I'm not a forensic accountant, and I know you appreciate that, so I won't be able to answer it as definitively as I'd like to, right? But I mean, it is a difficult one to get right. First of all, in 2017, I think the overrun was much higher than that. This year we're taking 139 million of the 2017, but there was a supplementary estimate of 200 million on top of that in 2017 as well. For the year ahead, like, you could ideally say, look, we're going to put in 300 million there for unforeseen, unexpected, unanticipated developments in the year ahead. We could put in 300 million, but straight away that will be absorbed and used up in the day-to-day running of the HSE, and it won't be there left at the end of the year. So it is a bit of a blank cheque, and it may loosen the whole checks and balances and value for money, or there may be more political decisions taken. Sure, isn't there 300 million there? Let's do this and let's do that, or let's do whatever, or pay awards or whatever on the back of that. So it's difficult if you do it that way. And I'm doing really macro now, headline stuff, as opposed to getting into the detail for each year. That is one step that could be done. So then what you do is you just try, learn from the previous year, learn from the anomalies that arose and learn from that and try and use that into projecting as best you can for the year ahead. But there is an ebb and flow that will always have to be there, and that tension between allowing an envelope to, or a little bit of headspace or headroom in the fiscal space, and yet at the same time that will be gobbled up with some demand-led service.
I suppose the point I'm making is if you repeatedly do what you did last year, and expect to get a different result, you're probably being over-optimistic.
Yeah.
So, for instance, there was a shortfall of 85 million in income from private insurance companies because insurance companies ran a campaign advising patients that they shouldn't be admitted as a private patient unless they felt it was going to be a benefit to them in a public hospital.
Yeah.
So that's a substantial hole in a budget of 85 million. And in relation, so perhaps you might speak about that first. How can that hole be gapped? Because Sláintecare speaks about removing private care from public hospitals, and there will be a hole of 625 or 635 million if that was to happen over a period of time. Yet it's actually happening at the moment because insurance companies are adopting a different policy in relation to their policyholders, advising them not to sign that they're a private patient when they're going into a public hospital, because they'll probably get exactly the same treatment as a public patient. So that is obviously going to happen year on year. So how will that be addressed in this year's service plan?
Well, the overarching issue of the public-private and the challenges that are presented there, as you know, are the subject of the Butler report, and I think the Minister expects that by year end. I think now I can't. Yeah, I think is my last conversation with the Minister on that. It certainly is imminent. It certainly is imminent, and that's going to address a number of issues on both sides. There'll be positives and negatives to that, and that would have been agreed by Sláintecare or recognised by Sláintecare as well. But there will be financial implication. How do you adjust for that? Well, with the first is you have to project for it, right? But you have to try and balance that on the other side of the house, and that's why we introduced VIPs last year, value improvement processes, where we can try and, and the Deputy was trying to get to the heart of where we're identifying that figure. You can try and, meet somewhere along the way there that will address some of it, but it won't address all of it. So increased funding is probably the main answer, how we're going to address that shortfall of 635 million as a result, if that's what it comes to be. If that's what it comes to be. We'll try to mitigate it. I was recently out in UCD at the Lean Sigma initiative, which is it's a very, very impressive initiative that's taking place in healthcare in association with academia, where they're trying to identify cost savings, and that's obviously an annual ongoing challenge that we have to embrace more and more, to try and do more with less, try and lower the level of care. I mean, sending people into the A&E for everything under the sun isn't the answer to, we need to try and change our processes and reduce costs by getting people treated lower and all of those kind of things as well.
So that's the point I'm making. We have to change the structure of the health service and reorientate it away from everything being sent. I mean, our health service is designed for people to end up in hospital. That is the default position for everything.
Yeah.
The design of our health service should be that everybody ends up in the community and only goes to hospital in complex cases or in acute emergency situations. So how is this year's service plan going to start to reorientate the service away from the expensive hospital system and towards the less expensive community care system?
Okay, well, there's a number of things. First of all, the transitional care beds. There's an increased focus on that. That's step-down care, lower level. We all know the differential between keeping somebody in an acute is anecdotally said to be costing in the region of €7,000 a week and about €1,000 a week in a community setting, in a community hospital. So opening more transitional care beds. Obviously, we're increasing the capacity within the acute system as well simultaneously. We're renegotiating the contract with the GPs. We hope to have that completed by Christmas. It's ambitious, and there's no guarantee that will happen, but we're very confident. And there's going to be a number of different measures involved in that, which will be moving towards that Sláintecare ideal of bringing more and more. One of my own hobby horses is telehealth. I think that offers enormous potential for bringing healthcare closer to the person, using primary care, where the GP can access consultant guidance, if you want, and advice and cover there and then from the primary care centre. Now I'm concentrating more in mental health on my own side of things, first with telepsychiatry, where we don't have to have a consultant psychiatrist on site at every ED 24/7, 7 days a week, 365 days a year, that we can have actually provided by telehealth, somebody in a hub providing consultant psychiatry to 6 or 7 sites on a 24-hour period, one person doing it. So there is many different strands that will be done, and this is going to be led out by Laura McGahey, and there's about 20 million euro, I think, to drive forward that. I mean, I see this argument made on Twitter and places like that. You know, you only allocated 20 million euro for the implementation of Sláintecare this year. You know, but I mean, Sláintecare is a policy implementation. It's a shift in practice. It's a shift in whatever. It doesn't require that sort of upfront massive €2 billion funding straight up. You know, as you lessen the level of complexity and lower the level of access for people and bring it to them closest to their home, you can avoid an awful lot of the very expensive, reactive, acute-led hospital or acute-led medical care that is kind of evolved really in the country. And look, everybody recognises its dysfunctionality. Everybody understands, I think, and accepts division of Sláintecare and agrees that that's the way forward. But I mean, to reorientate a ship the size of the HSE and a service, there's going to be, you know, many steps along the way to do that, and a number of those will begin in the year ahead.
Thank you, Minister. Deputy Chambers.
Sorry to go in and out, Minister. I may ask a couple of questions that were mentioned before. Just on a point you raised there, the issue of telehealth, before we go into the budgetary allocations, what regulations are you preparing to oversee the rollout of telehealth care? We had the Minister for Health before us in recent weeks, and there, as we know, in an Irish context, there are none. There's been criticisms from the Care Quality Commission in the UK about some of the dangers of telemedicine, its development and inappropriate prescribing, and the lack of part of the clinical examination that occurs. So, what regulations are being developed to match your ambition with telemedicine? Just on the first question.
Okay, thank you, Deputy. It's a conversation I think I had with you a long time ago. You raised that in the Dáil. It's a very interesting debate, the whole telehealth, and I suppose, in essence, it doesn't require a whole lot of additional regulation. I mean, telehealth is a platform. It's not a new way of doing medicine. It's just a platform. It's a communication tool. It's a screen to screen. At the other end of the screen is a fully regulated doctor or a consultant. For example, in my own area, consultant psychiatry. And I want to deliver consultant psychiatry from a hub in Dublin, or it can be anywhere, as it happens. It can be Cork, it can be Limerick, where there's one room with a consultant psychiatrist inside that room, and instead of having to be physically present below, covering the Limerick ED and covering the Cork ED and the Tralee ED and the Clonmel and all the different hospitals, the EDs, different hospitals, Naas General or whatever, that he could cover 5 or 6 of these sites from one hub. And what you need is technology at both ends, so that when my 14-year-old son presents at an A&E in a state of psychosis at 2 in the morning, I can go in there, and instead of being told there's no consultant psychiatrist available until 9 o'clock in the morning, that they'll actually turn on a screen there in front of me, and there'll be a consultant psychiatrist who will speak to my son. He can assess him, he can diagnose him, he can prescribe, and he can admit, if necessary, to an adolescent unit.
Have you engaged with the Irish College of Psychiatrists about this?
I have indeed, extensively, and I've had numerous engagements with the College of Psychiatry, and they're very enthusiastic and very supportive of this development. I held a national conference in the National Centre, in the, whatever it's called out there, the Conference Centre, and I brought over clinicians who were doing this in the States and from Australia and places like that to speak to the Irish clinicians, and it was deemed to be an unqualified success day from the clinicians' point of view, because they learnt about this new way of doing it, and we challenged all the challenges that are there. We asked all the questions the clinicians did, the practitioners, the managers of the health service. There was 200 or 300 people there on the day that questioned all these people and got to the bottom of it. So there is no need for us to reinvent a wheel that's already moving. But like, I was doing this 20 years ago in education. When I was a school teacher down in Lepp in West Cork, we were giving special needs teaching out to the islands through technology, rather than the special needs teacher having to leave Lepp school and go out to Baltimore and get on a boat and whatever. Well, you know, this is bringing the healthcare 20 years on. No, it's a platform. And I know your concern is video doc about prescribing.
Well, no, with respect, I think if a 14-year-old presented with psychosis, the care provision for them because of a vacuum around recruitment shouldn't be a screen. And I think as Minister for Mental Health, your priority should be ensuring you fill the recruitment gaps in our hospital system, and that we're not replacing and diluting proper care provision in our acute hospital system, because you're mentioning not having to have a consultant on site 24/7. They're not there anyway. But we shouldn't be diluting proper care provision and proper appointments for something that isn't the same. So no matter what, face-to-face will beat telemedicine. and we shouldn't have a policy of diluting the quality of care. And I'd say if you were to ask any 14-year-old, they'd prefer to have a team there to see them when they present in an acute basis than to be handed a video screen or something like that. So whilst it's fine to be developing a process of telemedicine, I think it's important to be careful that we don't replace a proper recruitment provision in our acute hospital system, because at the moment, if you do present at 2 in the morning, as you know, a lot of children who present are having to be admitted to adult beds. They're not being seen by paediatric psychiatrists, and we shouldn't be, trying to encourage a paediatric psychiatrist to, or child and adolescent psychiatrist to, to go for 6 hospitals. We should be filling the recruitment gap, and I think that's a failure of government policy around recruitment, retention, and around pay. And I wouldn't like to see dilution occurring and a replacement of proper recruitment gaps, because I just fear that this, whilst it's fine to develop something different, it shouldn't replace proper direct care, which is seeing the doctor at the hospital interface. But I'm going to move on to...
Sorry, Chairman, I do have to respond to that, because that's a very lengthy... it's a very lengthy and substantial, and I couldn't disagree with you more, Deputy, 100% more disagree with you. It is a matter of absolute fact, I don't make any of this up, that there is a worldwide shortage of consultant psychiatrists. We are short 60 of them in Ireland. Now, I can't make 2 of any one consultant, no matter how hard I try. I can try breedium, I can try clonium, I cannot make 2 of one. All the government policy and the pay and everything else won't make 2 of one when there is a worldwide shortage experienced by the United States, experienced by Australia, but experienced by everywhere else. What they have done in Australia, what they have done in America, what they have done in the rest of the modern world is they have caught up and used technology to utilise, because we have so many consultant specialties now. At a time there was, you just had a consultant psychiatrist. Now you have consultant psychiatrists for adults, you have consultant psychiatrists for children, you have a consultant psychiatrist with a specialty in anxiety, you have a consultant psychiatrist in eating disorders for children, eating disorders for adults. It's been, but we don't have enough of them as people are presenting their drones. Technology is merely a platform. It is not, if there's a consultant at that screen, that consultant is fully trained, fully qualified, fully accredited, fully everything else. You are not diluting the level of service to the child. Would I, as a parent, prefer to go into CUH tomorrow morning at 2 o'clock and be told we don't have a consultant psychiatrist available until 9 in the morning? However, I can put you on to a consultant psychiatrist immediately who's there, who's qualified, who's whatever, can speak to your son, can assess, diagnose, prescribe, admit if necessary. Which would I prefer as a parent? Would I prefer my child to be in a state of psychosis, in the A&E, and the craziness of it from 2 in the morning until 9 the following morning? Or would I would happily accept. In actual fact, it has been proven that children with autism are more comfortable using a screen, but I am not suggesting that a screen is superior to face-to-face. I'm just saying, in a situation where there is a vacuum of 60 consultant psychiatrists in Ireland, I have 2 choices. I can continue to do what I always did, which the Chairman referred to there. If we always do what we always did, we'll always get what we always got. And I can tell PQ after PQ that we have recruitment and retention challenges. I, as Minister, can accept my responsibility, step up to the plate and look at a new way and an alternative way of doing how we do what we do to ensure, because it doesn't make sense to have a consultant psychiatrist sitting 24 hours a day inside an A&E and maybe 2 presentations for them in that period. We have to be real about how we do. This is not to replace human beings. This is just, we have, for example, at the moment, we have a vacancy down in Wexford where we have a consultant psychiatrist who left post very famously at the time, where he did it in very high profile. So I have a consultant from Galway who's going down there every weekend delivering clinics to teenagers, to child and adolescents. And she is travelling 7 hours of a journey up and down to do that. Now, I could remove those 7 hours in the morning by having a screen. She wouldn't have to leave Galway. She can assess her patients. They're below in the middle of a team. They're not being done remotely. When you go into any, you're seen, but there's a GP, or there's a doctor, a physician there, there's a psychiatric nurse there, there's registered general nurses, there's a whole team of medics around. The consultant psychiatrist is part of that team, but they're not physically present, and they have their input via screen to just make more available this precious resource that is not there in full for all of us as much as we'd like. It's the same with the consultant in Galway, who has a full CAMS team. As you know, it's a multidisciplinary team, 8 or 9 professional people there, but they're led by a consultant psychiatrist. And when a consultant psychiatrist leaves, I don't want that team to be paralysed. I can have a team or a consultant psychiatrist from another area come in, using technology and discussing the cases, discussing the caseload and giving advice to the psychologists, to the occupational therapists and so on and so forth. That's on telepsychiatry. I just want to give that response. Thank you, Chair.
Yeah, thanks, Chair. Well, look, I see it as a dilution of the commitment around recruitment, so we'll agree to disagree in that, and I still believe it's better for a 14-year-old in the circumstance you've outlined. And also under the ICD guidelines, that actually, if you look at the mini mental state exam, the whole process of examination, I'm not sure how the full criteria can be met according to international guidelines. Whilst there might be advances in this, I still think if we're going to reflect the Sláinte Care vision of healthcare in Ireland, what you're doing to replace proper recruitment and with telepsychiatry, whilst you can build a platform and it's fine to have a vision, I think that the focus should be on replacing the posts. I'm going to ask just about what you haven't mentioned in your statement is what I see as the elephant in the room in the HSE, which is around spending, which is the 80% rise in management in the last 5 years. In 2012, we had 744 grade 8s. Now we have nearly 1,400. And what are you doing, and what are your department doing to address the continuous growth? It seems the first thing every year in the HSE and in the Department of Health is to fill the management positions for people at middle and senior levels to have a merry-go-round of filling the vacant positions. It's the constant spend, it's the bloated reality in terms of healthcare in Ireland. And when you have the frontline workers, whether it's doctors, nurses or healthcare professionals, or even the frontline in terms of secretarials and clerical staff, they're the ones at the coalface who are told, no, you have to manage, with someone goes off, you have to manage as you do. But the bloated top continues to grow, and I recognise you're only there 2 years, but I think as a minister, there is a duty of oversight to say stop. And I'd like to know, what are you doing as part of the budgetary allocations to stop this continuous bloating that we have in healthcare organisations, which everyone on the front line is frustrated by, and the growth in figures. Even during the peak of the recession, people were continuously promoted into more senior positions. Their positions were filled, and it's continuously becoming more top-heavy. And I think if we are going to grapple with difficult budgetary allocations, it needs to happen at all layers and levels, and management is a huge issue, because we know from the HSE coming before here, there's no one taking responsibility. So we've lots of managers in lots of different areas, but the buck stops with nobody, and they're not meeting any of their targets or outcomes every year. If it's the acute hospital budget, we had Deeper saying hundreds of millions being allocated, no idea what the output is, no idea what the service level improvement has been, but we've more managers managing that budget every year. So I'd just like to know, what are you doing in terms of planning as part of the HSE to address the continuous bloating that we have?
Thank you, Deputy Chambers. The Minister.
Thank you, Chair. Yeah, this is a very familiar political chestnut that's thrown around a lot in these fora. The issue with HSE management, and I'm not a spokesperson for the HSE. I have a responsibility within the department that oversees the work of the HSE. But the point I make is the HSE are better able to answer these questions themselves, but I would give a broader context for it. I hear politicians make this point, and it's very popular to make it, that there's lots of managers in HSE and they're all having fat cats and massive salaries, and they're promoting themselves and all of this kind of thing. We as politicians, first of all, have an accountability here and a responsibility here. We demand all this accountability. We demand, the millions of people, or the tens of thousands of parliamentary questions that go in every day. We want answers. I mean, the last deputy that brought this issue up with me on the floor of the Dáil is probably one of the deputies that submits more parliamentary questions than any other deputy to the HSE, one of them. And yet, we can't have it both ways. We can't expect all of this accountability. We can't demand that we get all these answers. We can't expect them to be in here before us on every issue that arises on the 9 o'clock news that night and bring in a team of them. We submit thousands and thousands and thousands of parliamentary questions. We make representations in their absolute tens tens of thousands. Somebody somewhere has to deal with them, and they're not dealt with by nurses or by doctors or by frontline staff. They have to be dealt with. Secondly, we have a hugely increasing demand of level of clinical governance, corporate governance, financial governance, and rightly so, and accountability. And somebody has to be responsible for all of these. And again, this is within management of the HSE. During the recession, it is a matter of absolute fact that there was a pause put on recruitment of managerial positions within the HSE unless it was absolutely necessary. No, Deputy, I didn't interrupt you, so if you don't mind letting me,
That's not how we conduct business here. So if you let the Minister ask his question or answer the question, thank you.
So there is an increase in the rate of recruitment of middle management since the recession has lifted and since resources have come back into play and since the government has been in a position to increase funding, because during the recession and during those very difficult years of this country and for the state, there was, we did everything we can to protect the recruitment of frontline staff and to continue the recruitment of frontline staff, but there was absolutely a pause applied to management positions during that period. So now there is a catch-up phase going on there in some of those. So it would appear, if you look at the figures, that there's an increase in it. But as I said from the outside, Chair, like there is international comparisons here. An organisation the size of the HSE with the employment levels that there is, and as a percentage how much management team was there and whatever. Those international comparisons are there to be seen by anybody who wants to look at it and look at similar organisations with similar and the percentage of staff that are employed to manage such organisations. And when one looks at the broader picture rather than the cheap, popular, political kind of opportunistic shot, actually when you look at the hard facts and data, it's not something that unduly concerns me, and I'm entitled to my opinion as a minister in the department. I have no beef to protect the HSE from anybody or anything. They're well able to answer themselves or whatever, but it's not something that gives me concern, and I can only speak as I see it.
Just on that point, Minister, if you speak to frontline staff, be they nurses or doctors, public health nurses, community intervention teams, they all say that they are overburdened by bureaucratic management, that there is a profusion of management over and above what is necessary to deliver the service. In fact, they find that the bureaucracy inhibits their delivery of service because the amount of work that they have to do to comply with the increasing amount of bureaucracy that's being applied to their work, it's taking them away from their patients. So that's the first point. But the second point is there is evidence from frontline staff that the managerial system is overburdened by management and it is interfering with the delivery of service. So yes, maybe it's a political point, but it is a very practical point coming from frontline staff that there is a profusion of management which is actually interfering with the delivery of service rather than enhancing the delivery of service.
On numerous occasions as well, Chair, as any practising politician will hear that from the frontline staff. The issue I'm trying to bring is to broaden the perspective of how we view this and how we narrate it, and that's where I bring in the political side of it. It's where we narrate about bloated, overpaid, whatever, all that. But on the real substantial facts of the matter, what is driving, and I accept that there is an over-bureaucratisation of the HSE management, no question about it. But what is driving that? What is driving that? Politicians and the courts are singularly driving that. It's politicians and the courts and the level of, we talked about the awards earlier, the accountability, the demand for all of these layers and layers of, that's where bureaucracy comes from. Bureaucracy comes from things like, European directives and all of these things. That's what drives bureaucracy. There is not a culture within there of let's create layers and layers to make life difficult for everybody. But every time there is a court case and every time there is a parliamentary accountability held, whether it is before the public, whatever it is, PAC, before it's any of these or parliamentary questions or whatever, we are demanding all of that as well in tandem. So we can't have it both ways. The amount of work that is in the Parliamentary Affairs Division, the amount of people it takes to service the Oireachtas at health. Now, we have to accept that is driving it. Now, do we want that level of accountability or not? These are just, they're factors in the debate. That's what I'm making. I'm not giving a blanket defence here of what the HSE is doing in terms of management, but I'm telling you there is another side to it as well that we have to accept.
Thank you, Minister. I'm going to bring in Deputy Durkan. You can come back in again. Well, I cannot control the amount of time it takes you to ask a question. So you've had the floor now for 15 minutes. So I'm moving to Deputy Durkan. You can come back in again. We can stay here till 1:45.
Deputy Chairman, Thank you, Chairman. I served my time on one of the health boards, in fact the biggest health board in the country, and I learned a few lessons in the course of that as well. And as I have said many times in the past, Mr. Chairman, I don't think the HSE is the appropriate structure to deliver services to the country at all. And the sooner we get back to the regionalisation, which is proposed in part in the context of sludge care. However, there are issues. I don't accept the notion, that implicit in what you say, Minister, that asking too many questions is slowing the system down, is costing a lot of money. Now that's rubbish, and I've lived that with many years. It costs no more to answer a question quickly than it does to answer it slowly. In fact, the reverse is the case. To answer it slowly, it costs, I'd say, it could be up to 10 times as much. Plus the fact that the very fact that a question can't be answered gives a cushion to people who are afraid of a question being asked in the first place that they don't deserve. So I would have to say this, 2 or 3 things. First of all, how does the system work? Is the system working? I don't think it is. A simple thing would be the transfer of a patient, a seriously ill patient, from one part of the country to another, from one hospital to another. That's a major issue. That shouldn't be a major issue. That should be a very simple thing to do. And I had to deal with one during the summer. And ironically, the patient was a private patient. I would have thought the public health sector would be delighted to grab a hold of this private patient with health insurance and all that goes with it and all that kind of stuff. No, not really. It wasn't. Shortage of beds was a problem now. Now, this guy was in a coma. And why have we a shortage of beds? Well, we have only a couple of beds and they're for emergencies. And what do you think this is, if it's not an emergency? So this is the way the conversation goes. So I think, Mr. Chairman, there's a good case for walking down along the conveyor belt and finding out what in heaven's name is slowing the system down and why is it not working in the way that it's supposed to work. Any system that Henry Ford once devised a system that was way ahead above everybody else's, worked far, far better, produced something much quicker, more effectively, cheaper and better. So I'm not suggesting that we do things on the cheap, but I believe that we can do it an awful lot better and quicker and more effectively and efficiently than we're doing it at the present time. My last point, Chairman, and I would like the Minister to maybe address this for a minute, the use of the treatment purchase scheme as a means of removing the most sensitive areas from our waiting list. There's no reason in the wider world you have to pay for it one way or another. Somebody has to pay for it. So if it can't be done in one system, let's do it in another system. Inside, outside the system, inside the country, outside the country. I don't care where it is. We have to set a situation in motion whereby there's an inevitability about everything. It happens, and if we can make it happen, then we should get somebody else to do it. And the point I raised previously in relation to, for instance, it has become, and this is not a reflection on the present government or the previous government, it's gone on for years. Patients may be waiting up to 10 years for a hip replacement. There's no need for that kind of thing at all. In severe pain, excruciating pain. And somebody says you take more, to go to the GP, get more painkillers and so on and so forth. That's all wasting money. The time to use the time effectively is to go to the centre of the issue, deal with it now, and that way we won't have to chase after the wagons in the future. And the last point I'm worried a little bit about is I referred to there, the State Claims Agency and the increasing costs. Are there not reasons for these increasing demands? Like, is it a culture, or are there a greater number of situations arising where the state is exposed, arising from the delivery or non-delivery of the services, as the case may be? And I'm not going to go into the issue of unqualified medical personnel who obviously were infiltrated the system, and we've gone through that in the previous area. But, the existence of those kind of issues would cause me some considerable concern.
Minister, thank you. Thank you, Deputy Durkan. Minister.
Yeah, look, can I be just abundantly clear on the HSE management issue? I am not here to defend that is the ideal system, or to say that is what I desire or what I want to see or anything like that. I'm merely, in the interest of the debate, contributing another angle to the debate. you know. But of course, I have no difficulty with people holding to account and questioning it. I'm just saying we have to be aware of the other sides of it, some of the responses they will give. And do I want to see that accountability continue? Yes, I do. Do I want to see that transparency continue? Yes, I do. Do I think that the HC should be given a blank cheque and said employ as many managers as you want? Absolutely not. You know, so I agree with a lot of what you're saying, but I just have to put it in context and broaden the debate somewhat more in the interest of the debate itself. It's not in the interest of winning or losing or scoring or politics or anything like that, or me being defensive as a minister. I have no issue at all with taking the challenges head on. The private public, I mean, our Deputy Durkan talks about management, you know, and the style of management within the HC. And if you look at the private hospitals and see how they're run, some of the private hospitals, and they don't have the layers of management, and that's the point you're probably wanting to make, Chair, as well. They don't have the levels of management that you have in the public hospitals. There's no question about that. There is much more management attached to it. And if you look at the efficiencies of the private hospitals, you know, they're probably a lot more impressive in a lot of cases than they are in the public. But then the public or the private hospitals don't have the kind of issues that they have. They're not probably have the same level of union issues. They don't have the issues with public accountability, where they have to come before us or different organisations, or you know, prepare PQs and all of that side of things. They don't have to deal with FOIs, you know, media queries and all that to the same extent the public do. There's an element of that caused it. And again, I'm just saying that by way of contribution to the debate as opposed to defending what's happening. It's just it's a difference. Many people in this chamber, if it was full, would be very vehemently opposed to any further privatisation of health services, and that's not the way to go. That's an ideological position that some people take. So, you know, there's a debate all around whether public versus private, what's better. You asked about the NTPF and the purchasing power that they're giving and the increasing power to purchase. A lot of that, obviously, as we're aware, is within the system itself. It's identifying where there's capacity and moving funds around in it. Your last point was, Deputy Durkan, I'm not sure what was the...
Why is the system not working smoothly? There was a reference made following an investigation recently about the chain of command. How is the chain of command operating? Because I don't think it's operating at all, and I don't think it has operated for many years. Certainly since the health boards disappeared, and the regionalisation disappeared, and there appears to be an amorphous mass somewhere in the centre of kind of a hazy area, a foggy no-go area, Mr. Chairman. Full of pitfalls and traps and all sorts of things, and nobody seems to go there. And everybody I think I know what the Minister is hinting at, you see. Everybody's afraid of something. What are they afraid of? If the system is working properly, there's nothing to be afraid of. Everything is done in accordance with the rules, fine. Then accidents will happen as well. But I mentioned the state claims and the claims, the various causes of the claims. Okay. And I think the size of the claims and the severity of the claims, I think, is one thing. But I think the reason for the claims is another thing. And I've dealt with a couple of cases now in recent times myself, where there was a clear indication to me that something wasn't done that should have been done, and there was a patient suffered as a result. A reluctance to admit it, even though we have full disclosure supposed to be in operation now. A reluctance to admit it. So what do you do? I would have thought in a situation like that, the management would say, OK, we'll make a tentative offer, whatever the case may be, without prejudice offer, whatever. None of those things happen. It goes to law, goes into court. And eventually, in the steps of the court, somebody decides to settle. That's not the way to do business.
Minister.
Thank you, Deputy. I suppose you asked, the first question you asked is why is the system not running smoothly or operating smoothly? If I could give you a succinct, articulate, coherent answer to that in a couple of lines, I'd be a fairly formidable individual if I could answer that question in a few succinct lines.
We believe you are, so that's why that's the question.
Thank you for the vote of confidence in posing the question anyway, to think that I could do it justice. On the size of the claims and that, yeah, look, you're asking the question, is it just an increase in the size of claims or is the number of claims increasing? I remember actually in the last Dáil, as backbench TD putting in some PQs on this very issue of the number of claims, and there wasn't, I thought by looking at headlines of the papers in 2014, 2015, that there had been a massive increase in the number, but there isn't actually. I don't have the latest figures for 17 and 18, but back in 15 and 16 there was no massive increase in the amount of claims actually, or the amount of things. So you're right, and we have made a cultural shift, of course, towards open disclosure. We're trying to get people, and we're trying to deal with that legislatively as well, that people will be admitting their mistakes and owning up to it and acknowledging it and informing the person who's the victim. We also have the Mediation Act, which is to try and avoid the courts. And as I said, we have the periodic payments as well to try and stagger those massive payments, that they're not all done individually at a time. But that in themselves, we obviously have to reduce the amount of claims. But there is an increase in the amount of procedures taking place in our hospitals, and I suppose a pro rata increase. I don't know the definitive answer because I haven't seen the figures for 17 and 18, but there would be a pro rata increase in the amount of claims, I suspect. I don't know, I would hope not, but that there would be potential for that. Also, the establishment of the HSE board, I think, will be a positive step towards what we're all talking about here, the oversight of management and holding management to account and ensuring that management isn't overly bloated or whatever. I think a good, effective board that will be challenging the top layer of management of the HSE will be a very positive step, and that's something that's being established in the new year that I hope would, what the four of us here very much agree, needs to be challenged and held to account and open to scrutiny, is the levels of management within the HSE.
Thank you, Minister. Minister, could I come back to the pure estimates again? The overrun in the various regions ranges from 86 million to 118 million. And you've spoken about why those overruns happen, because it's demand-led service and there is an unpredictability about various flu epidemics and weather storms and snowstorms, etc. But, Minister, there is a predictability to health. So, for instance, 3,500 people will fall every year and break their hip. It might be 3,400 one year, it might be 3,600 the next year, but there is a predictability about it. And there's a predictability about many chronic illnesses and how they're going to present to hospital. And there's also a predictability about the ageing process. We know that 20,000 people a year go over the age of 65, the ageing population is increasing. Those over 85 will double in the next number of years. So these are all predictable actuarial events.
Facts, they're facts.
So surely you can predict the cost of looking after that variability. And that's the issue, because each year the prediction of that variability is off by 600 or 700 million. So the issue is, we're spending as much money as the average country in the OECD on health, but we're getting substantially poorer outcomes. So continuing to do what we're doing, as I've said before, isn't giving better results. So the actual change that I'm trying to get out of you, I suppose, or maybe feed the idea into you, is that there is efficiencies to be gained by integrating our services. And our services are not integrated. And because of that, there's a lack of efficiency and there's a lack of value for money. And what Sláintecare is proposing is that there would be a huge level of integration. The first part excuse me, is integrating hospital groups excuse me, and community health care organisations so that the budget would be a single budget, and that would drive efficiencies in hospital admissions, in hospital discharges, in transferring care to the community. So can you say that there is going to be that move in the coming year to bring about that change in efficiency? Because we can keep throwing money at the health system, but if it's inefficient, it's not going to deliver value for money. The only way of delivering value for money is to have integrated services, which by default will bring you efficiency. So perhaps you might comment on that.
Yeah. I suppose, can I say definitively that those efficiencies will be brought about in the year ahead? No, I can't. Okay. Can I say definitively that there will be a relentless focus on bringing about those efficiencies? Yes, I can. You know, we have a very dysfunctional, I suppose, architecture underpinning our health system, and you'll be aware of many of those, and integration is key to the solution to actually achieving a more cohesive and coherent health service delivery that works for people. I had somebody into my constituency office recently, a number of weeks ago. They had been in Germany and they showed me the card, which is the equivalent of your driving licence card now, the new card, with a little gold thing in the middle, and that's their health record. And every interaction they have with the health service since the day they were born is on that one little card. We don't have anything like that in Ireland. So if I go into the South Dock to go to A&E, to go to the acute, back down to transitional care or whatever, and the shifting of files and the paperwork that's generated, and the lack of joined-up awareness as well in prescribing and whatever, I can be prescribed the same thing twice or 3 times. You know, there's anomalies arise in the system because of the infrastructure. So that is the biggest challenge that I see, and I don't have any monopoly of wisdom on this other than from my perspective. As a Minister of State in the Department of Health, is actually to get the IT infrastructure up to scratch, and if we can have that, then we can have the integration. It's very, very difficult to achieve the level of integration that you desire, and that you have a unique perspective that I don't have, but that I desire as well from my unique perspective, is actually the IT system that will allow that and facilitate that. So that's the single greatest challenge that I see, and I would think that until we put a relentless focus on trying to get that together, you can achieve so much more than when you have data sharing, when you have information sharing, when you've, everybody can speak to each other at one and all of that, both clinically and medically, but from a management point of view and so many more. And the information we seek here as parliamentarians, holding to account, will be so much more seamless again if that IT infrastructure is put in place. So that is the single biggest challenge. Can I say we'll have that achieved in the year ahead? No, but will there be a relentless focus on it? Yes, as you know, we've got €250 million from the European Investment Bank with a view to establishing the European Health Record, to try and buy the infrastructure necessary to do that. That will take us a significant step towards it, but there's a lot of other IT challenges required within the system. As you know, there is an integration going on between the CHOs and the hospital networks to align them as well, and that of course will make for much better information gathering, sharing, provision of health service delivery for people if they were aligned as well. Obviously with the whole issue that I'm very animated about, which is delayed discharges and all that, you need that tie-up between a community healthcare organisation and the acutes, which isn't there at the moment, and never the twain shall meet. One is my domain, one is your domain, and trying to get them to join up is very difficult. So, I think we're probably getting very good, and have, thanks to Sláintecare, at recognising and distilling down the key challenges and the optimum ones that we would get best results from, and it's now to move along that journey of Sláintecare.
Deputy Chambers.
Thanks, Chair. Minister, to get an update on the Children's Hospital budgetary allocation, has that changed in the estimates going forward in the capital allocations that you've mentioned? That's just the first question. My next question relates to, you mentioned in the statement that the obviously, as the Chair mentioned as well, you're on one level in Sláintecare implementation strategy, you're saying there's going to be a complete split between public and private care, but on the other level you're saying, well, we have a shortfall here, that's a problem. So there seems to be a kind of a perverse incentive there, where public hospitals are obviously reliant on the private income that they're now losing, but government policy is to remove that private income. So I'm just wondering, what's the weaning phase and the plan for private care in public hospitals under the Sláintecare plan? Because, if we keep having, I suppose, a department position that states reliance on this private income in public hospitals, then the whole Sláintecare ambition won't be achieved. So I just want to know what your thoughts are on that. And just finally, I was going back to the final point. I respect that you want to give a position in terms of management. I think instead of saying it's an old political chestnut and an opportunistic type of comment, there is a huge problem. The Chair mentioned it. Everyone working in healthcare gives feedback to us and to you, I'm sure, that there is an issue. We're spending one of the highest spends in OECD terms, and if you look at our level of frontline output, it's lower down in European terms. It's probably below average. So we have a mismatch, and it's not because of investment or spending or will on your behalf, but we have a lot of management that aren't managing that budgetary allocation. And as Deputy Durkan mentioned, whilst you talk about accountability and transparency, we're not getting any accountability from any. We can't even identify who the managers are and how they're matching their targets because there's so many of them. If you have 8 people responsible for a particular segment of a care pathway or delivery in a particular hospital, they're not accountable. And what tends to happen is what we've seen in the figures, which is they get promoted out of their positions and they're rewarded for not necessarily delivering on their own service plans within the healthcare system. And I think you as a minister, and indeed anyone in the department, needs to build that into the promotion system, into the management. And I'm trying to be constructive on that. I'm not trying to bring up an old political chestnut. I think it's a huge issue, and I don't think we'll ever have any progress in Sláinte care if we just continue to allow the layers to grow. And it wasn't your government, it's 20 years. It's an issue of all parties in the Department of Health, so I'm not laying the blame at your floor, but I think politically we need to grapple with it because like in the recent years we had the hospital groups were created. Now there's been a change of government policy to get rid of those and to replace them with a kind of a Sláinte care structure. So we've spent a number of years layering up hospital groups, and now we're moving and transitioning that into another structure, which would make me concerned that we're in fact going to add additional layers, because inevitably when you transition on an organisational basis, that's always the risk, and that's the lesson from the HSE. When we went from boards to HSE, layers grew, and I just hope that we learn the lessons from that going forward.
Thank you, Minister.
Yeah, thank you, Deputy. You answered there on the Children's Hospital. I don't have, the capital plan isn't agreed yet for this year, so I don't have the update if there's an overrun on the Children's Hospital, but I'll get that information for you, okay? If there's a projected overrun on the cost of the Children's Hospital, I'll undertake to get that for you. You talk about the complete split between public and private. The issue with public and private is the subject of the Butler report, as you're aware of at the moment, and that's imminent to the Minister, so I can't answer the questions to you definitively now of what proposed we'll do to separate public from private and to remove it until we get that report, and the details of that report will be used as a roadmap to achieving that, and there'll obviously be cost implications that we will have to handle as part of that as well. But I can't kind of go any further on that until we get that report. On the management issue, yeah, look, Deputy, I accept it, and I'm not trying to be provocative, and I think anybody that knows me would know I'm one of the least partisan, and when I talk about politics being opportunistic, I talk about myself and my party as much as anybody else, so I'm certainly not trying to be provocative on that, and I apologise if that's the way it came across. It's one of those things that sometimes, I suppose, when you hear people talk about our health service, it's people, whether it's at a pub counter or outside the church at mass or whatever, you're sure all the managers in it, that's the fault, that's the blame, and that's kind of a simplistic solution, that if that was addressed, we'd have a great health service or whatever, so there's balance required in the debate, and that's the point I was trying to make, but that doesn't take from any of the points you've just made there in your recent contribution, that it isn't a silver bullet, and that's really what I'm trying to bring across, that if that was reduced or halved in the morning, I'm not sure we'd be so much further down the road. Just on hospital groups, I suppose, Deputy, to clarify, we don't intend to change hospital groups as part of Sláinte care. I'm right there, Chair.
Minister for Health 2 weeks ago at the committee said that you're not legislating for hospital groups and you are changing hospital groups. He said that as part of the Sláinte care plan. Okay,
well, I'm not aware of that. The hospital groups have only been established 4 years ago now.
Well, that's the problem. That's my concern, that we've spent 4 years establishing something that you're now going to change and replace, and you're not legislating for them. The Minister told the committee maybe 3 weeks ago or 2 weeks ago that you're not progressing legislation around hospital groups to bring in a legislative and administrative framework, and that Sláinte care takes precedent, and they'll be replaced with whatever model Sláinte care proposes. So he told us, the committee, that, and that was the basis of my remarks.
Yeah, well, my understanding would be better aligning the existing hospital groups with the ambitions of Sláinte care, okay? And that would be accommodated in whatever legislative changes would be there, would be to better align the hospital groups. But I don't think there's a proposal to abandon the hospital groups or to disregard the hospital groups as they are. But it's better align them, I think, with the community healthcare organisation is the challenges that I've heard the conversation on.
He said he's abandoning the legislation that was set out that we're going to underpin
them or whatever. That might be to take account of the Sláinte care objectives of aligning them better with the community healthcare side of it as well, would be my understanding of that. I think that's your questions answered, Deputy, I hope. Yeah.
Deputy Durkan, are you
I'm fine.
Okay.
I'm fine now.
So, Minister, just again to go back to the estimates, In relation to the treatment abroad scheme, there has been an increase in a substantial increase in the cost of the treatment abroad scheme. Obviously, many people are going to Belfast, also going to England and other places, but mostly to Belfast. So perhaps you might just talk us through that. And the National Treatment Purchase Fund, again, is providing services outside the public system for public patients. The Treatment Abroad Scheme is providing services for public patients outside of the jurisdiction. So what is the overall cost of the combined National Treatment Purchase Fund Treatment Abroad Scheme for the year 2018?
Okay. I suppose just on the background to the treatment abroad scheme, it's a result of an EU directive which said that member states, individual citizens of any member state, can avail of healthcare in any other state within the EU as a matter of law, underpinned by a directive of the EU. So it is about awareness, as people become aware of that. Many people weren't aware of that for a long while, that they actually could travel to another EU state. It isn't just to Belfast. I mean, you could go to Spain in the morning to have your hip done and avail of maybe better sunshine during your recovery and so on and so forth. But that is a real prospect for people, so they can avail of healthcare in cross, and as people can come over to us as well, to Ireland, from other countries to avail. And there's different specialities and different waiting lists. Some countries have more capacity in their system for some procedures, and they have limited capacity for other procedures, and we have capacity for some areas and lack of capacity in other areas, and we're all aware of the ones where there's a lack of capacity. They're very well highlighted, but maybe some of the ones that there's capacity in, and I mean, Irish healthcare is very well sought after. I spoke to the head of the police force in Dubai 12 months ago, and they want to do a deal with the private healthcare in Ireland to do coronary care, cardiac care, because they believe the best cardiac care in the world is available in Ireland, actually, the Dubai Health Force, and have the most regard for that. But anyway, so that's different countries have different, stand out, and the Belfast issue is primarily the increase in it is due to awareness. People avail of it. The government is still paying for it, so it's a capacity issue.
Just on that issue, from what budget does the money for the treatment abroad scheme come from?
The overall health vote. It's part of, it's the same as, the acute hospital. I suppose it's the same as the acute hospital bill. It's the very same as that. It's added on to that because it's done abroad. It's under EU law. People are entitled to it, to avail of it. So we have to do it. I suppose Deputy O'Mahony referred to it earlier, about misunderstandings around it. That you'd think the way some people were talking about it, I think she's speaking probably politically, that it's, something that is not costing the Irish state. I mean, the Irish state, the Irish government, of the day, and the taxpayer of the day is still paying for these procedures to be carried out, whether they're carried out in Belfast or whether they're carried out in Dublin. It's about capacity, where you have capacity, and you have more capacity in Belfast in some of the hospitals, the private hospitals there, to do that procedure. On the NTPF, I'll have to get you more information on that. You asked me specifically on the NTPF about...
Well, the individual or combined cost of the treatment abroad scheme and the NTPF, because obviously it's an additional cost on the state outside of our public hospital system.
Right, okay. I think the NTPF was 30 million last year, was it? Or was that 55 million last year, and the treatment abroad scheme, do I have to put the... 12 million, they tell me is the budget for the treatment abroad scheme, 12 million.
Cross-border and then 14 for the treatment.
Okay.
And is it possible to get a breakdown of the procedures that are supplied through both the treatment abroad scheme and the National Treatment Purchase Fund?
That would be very interesting and very helpful, and we'll certainly get that for you, Deputy, so to get a breakdown of the actual amount
of the procedures that are carried out, the type of procedures that are carried out.
That are carried out, because I suspect, as I say, there's a correlation between where we have particularly long waiting lists and where, there's bound to be a correlation that will be interesting to view, and then where we have capacity as well. It would be interesting to see where we're delivering on the other side, where we're actually receiving monies.
And is it possible to get the cost of those procedures through the National Treatment Purchase Fund and the Treatment Abroad Scheme? The cost of a cataract or a hip replacement?
I presume we can get the standard cost. Yeah, we can get an average cost in. I suspect if there was 80 procedures and it cost us, 400,000.
Well, there is a perception that the cost of procedures in Ireland is more expensive, and the cost of procedures elsewhere. Okay. So, for instance, if somebody goes for a procedure in Belfast, cataract surgery, they are reimbursed the cost of that procedure from the HSE, provided the cost is less than the cost that it would
be here,
here in the state.
Okay, yeah. I suspect it would be very interesting for your committee. It isn't for me to tell you, suggest your committee, but it might be interesting for your committee to have that engagement with the NTPF yourselves, or with the HSE and the NTPF on that whole issue of the.
If you can get us the information, it might.
But I'll get you that. Of course I will, as I undertook to do so.
Okay.
I will do so.
When you were here 3 or 4 weeks ago at the quarterly meeting with the HSE, the interim director, John Connaughton, referred to the fact that there is an innovation section in the HSE which would look at innovative measures that frontline staff might spot or identify, which would lead to efficiencies in the service. So, for instance, in Scotland, there is a scheme where frontline staff are asked, can you identify within your sector how efficiencies can be made from your point of view, as opposed from having it coming from the top down, to have these innovative schemes being suggested and developed from the bottom up. I know it was John Connaughton who said that that was being developed, or there was such a section in the HSE. Perhaps you could make an inquiry in relation to that, because there are many frontline staff who can identify
efficiencies, and they would like to be part of the solution.
Simple efficiencies. And it works very well in Scotland that efficiencies identified from the front line are then developed within that sector and perhaps expanded out through the wider NHS in Scotland.
Okay.
So it's staff trying to be constructive, spotting a niche and developing it.
Yeah.
So perhaps you might take that idea.
I certainly will ask.
away.
I'll ask Mr. Connaughton to come back to you on that. And the Lean Sigma programme that I referred to earlier, that's one with UCD. Are you familiar with it? The Lean Sigma. Yeah, that's along the same lines as well, where it's kind of, I think there's 2,000 staff have been trained up in achieving efficiencies and working towards that same goal as well.
Well, one particular scheme that Senator Burke has repeatedly spoken about is hemochromatosis and the taking of blood for hemochromatosis in the community, as opposed to having patients going to hospital. It is substantially cheaper to do it within a general practice setting, but it never actually happens. It's innovations like that. And just the final comment, and it was brought up by Louise O'Reilly, and you did not accept it, but nevertheless, the ability to provide the 700 million supplementary budget this year for the HSE was undoubtedly because there was a windfall in corporation tax. And if we're to depend upon a windfall in corporation tax every year to bail out the health service, sooner or later that windfall is not going to be there. It's almost like depending on stamp duty that we did in the boom times to supply services. We're now depending on corporation tax, which is based on a few American companies operating in Ireland. And if Donald Trump was to change his policy in the morning, that could substantially change the income that we are getting from corporation tax. So yes, it goes into the general taxation pool, but in effect, it almost mirrored the amount of money required to bail out the health service this year. Just to make that point.
Okay, and I think my response to that is, Deputy, I think it's probably immaterial where it is coming from. Like, the more substantive issue is that we have an overrun in the health service every year of 700 million, or this year of 700 million, and whether it's being funded by a windfall in that, or whether there's an increase in some other taxation subhead, or if it's if the government gets whatever. It's probably immaterial what's funded. It's probably more important that it's there, and we could. My fear is that our focus will shift to the source of it, when we should have a relentless focus on why is there an overrun of 700 million.
I suppose the point is it's not sustainable.
Of course it's not, no matter where it's coming from,
Deputy O'Connell.
Yeah, thank you. Sorry for being late. And just following on there from Dr. Harty and his comments on hemochromatosis, there were pilots done with warfarin testing as well in the community. A bit like the hemochromatosis, there's absolutely no reason. In other countries, it's done in the community. But even from when we have generally older people, the bulk of it's older people on warfarin, that they're more susceptible to illness. And we saw from the last figures that I got that it was over 70s were the main reason for unscheduled presentations at A&E. And if older people who are susceptible to illness are constantly being exposed to the hazards of an acute hospital, well, it's only natural that they're going to be sicker. So, I mean, like the hemochromatosis, I see there can be efficiencies built in there with warfarin. And the flu vaccine in the community pharmacy worked really well, despite, I think it's 8 or 9 years going now. I was in the first tranche of people doing that, and that has worked really, really well. The morning after pill has worked, and any interventions yourself and the Minister have made to make it available at the weekend have worked. So we do have evidence that when you move things into the community, it can be more efficient, but also in terms of, it can be efficient in terms of burden of disease as well. And also there's a pilot in the, it's part of the system now in the UK. Another major reason for admissions to nursing homes and to hospitals is polypharmacy, incorrect prescriptions, errors. And there's incentivised for pharmacists in the UK where if you make an intervention on a prescription that is, 12 meds that can be brought down to 6 without interfering obviously with the doctor's orders, there's, I think it's like £5 or something. It's not massive, but there's an amount of money there to make it worth your while to do it and to do the paperwork. So I think we need to be looking at that sort of approach when it comes to, and we talk about sláinte care, it's all about moving from acute into primary care. But then when we look at it, what are we actually doing in terms of, as Dr. Harty said, the money will run out and services will be cut in the future if we don't, I suppose, bed them down into the community where other people, I suppose, to some extent, take responsibility for them. And I'm particularly concerned about the over 70s coming into the winter months, where I don't see, practically speaking, on the ground, any major interventions to try and stop them. I know we've proposed it, but if you could outline what interventions we are actually making to try and stop those people ending up in A&E in the first place, which isn't necessarily the right place for them. Thank you.
Thank you, Deputy O'Connell. Minister?
Yeah, I think most was probably statements you were talking about, which we've all agreed and readily agreed that the community is the basis of the reform of our healthcare system. And if we are serious about whether it's efficiencies or better outcomes or more people being treated, etc., it can be community-led. And as you said, interesting initiatives like that with the pharmacy, where there is a normal incentive, not a distorted incentive, but a normal incentive for good common efficiencies to be applied with the prescribing of drugs and the administration of drugs, and where people are, because as you say, there is a huge issue with older people taking too many drugs, taking the wrong drugs, not taking the right, as you said, polyprescribing and things like that, that it's different sources prescribing around the same issue. So if we could streamline that, that would, best of all, would be the outcomes for older people. You asked about initiatives for older people or whatever, and obviously as part of the winter initiative, that is something that's very much at the heart of it, where we're trying to do local, clinics and trying to extend the GP hours and, those which you've heard Minister Harris speak about numerous times in the last couple of weeks to try and address that particularly older people and particularly vulnerable people. You mentioned the flu vaccine yourself, and I spoke about it here earlier in the committee. That is, one particularly for all healthcare workers, and that to make sure that more and more people are taking that to prevent. And I referenced the point that in New York, in some of the hospitals there, if you're a healthcare worker, staff member on any level, and if you haven't taken the flu vaccine, well, then you have to wear a mask while you're coming in contact with people who are older, whether it's in the community, whether it's certainly in the hospital, in the acute setting. We're also looking at the whole area of increased home care packages, which you'll be aware of that announcement, to 550 intensive care packages. Also looking across delayed discharges, and a number of the initiatives that we're looking with delayed discharges is public communications policy, where we're trying to advise people, older people in particular, that the least safe place to be when you don't have to be there is in an acute setting. And that's kind of a bit of a challenge to the thinking, and that's a cultural shock to people, but it is an awareness, and with the amount of hospital-acquired infections that are there now, and that older vulnerable people can be very susceptible to be. Most of us think that the best place our loved one can be, who's over 70, is in a hospital, and that's the safest place for them. Well, we're actually, going to start a communications policy advising that it's not if you don't need to be there. It's the least safe place. And there's obviously other initiatives to try and, prevent people from, from having to go into the A&E first day. Working with Nursing Homes Ireland as well, again in trying to build awareness around the whole nursing home issue, and I suppose the admission to A&E should be a last resort if it can be avoided, and not just be the first option to people, again with the same focus in mind that it's not the safest place to be unless you absolutely have to be there. I don't know if that answers the Deputy's question.
Just in relation to home care packages and home help hours, what is the budget for that? Or what was the budget for that in 2018?
Okay, there was 17 million home help hours were provided in 2018. I think it was 426 million would have been the budget. Or is it 406 million? It's 426 million would have been the budget. I don't have it here to my right. I think it was 426 million was the budget for it. But I'll get that clarified for you. It may have been. And
what increase was that over 2017?
It was an increase of 26 million, I think, from memory. 26 million. I don't have those figures in front of me now, but I'm drawing from my mind. Which 26 million increase of 26 million from 2017 to 2018. And
are you aware of what the unmet need is?
Yeah, if we were to quantify the unmet need, it was, I think we costed it there, it would be somewhere in the region of about 40 million euro would clear the waiting list for home help in the morning, would be 40 million euro.
And is there an allocation towards that this year?
I expect there will be some increase towards it, but it won't come anywhere towards wiping it out. You know, it just won't come towards where it needs to be. And the point I've made about home care all the time is it is unsustainable, the current model of allocation. We have a number of challenges, as you'll be aware as well from practising politician, and indeed as your job as a doctor, that we don't have the people to deliver it either. So that's why we have undertook to actually prepare a scheme underpinned by statute and delivered like the Fair Deal scheme, where everybody who looks for it gets it, and that they will be fully funded. But we also need the availability of staff. So there's a lot of work going on in the background to ensure that we have those terms and conditions and right. But we also need to reduce the reliance on home help as it is in its current form, where we're sending it out 8 miles out and 8 miles north and south and all of that, you know, and get more options for people to age in space in a better, you know, environment, more suitable environment. And we're looking at, you know, supported retirement villages types efforts as well, which, you know, reduce the drain on home help massively and provide a much more enhanced level of care for people and allow them to live behind their own front door. And you'll be aware of Kilmaley as being one of the motivating
and
drivers.
And Kilmihil.
And where?
Kilmihil.
Kilmihil, is it?
We have one in Kilmihil as well.
All right. Oh, well, you will have to extend me the invite there.
Absolutely.
to see that, because I haven't seen that one.
We started at the same time.
All right. Okay.
We're only 10 miles apart.
Really? Yeah.
Yeah.
Oh, well, I will have to come and see that.
You have the invitation already issued to you now.
Okay. Okay. Thank you. Kilmihil. Thank you, Chairman.
Are there any other questions that our members would like to submit?
Well, there's only one last question, Chairman, that I hate to be putting this question all the time. You know the allegation that we hear all the time, and it's denied by some people within the health services, that we pay on par with the highest in the OECD countries, and we don't get service on par with the highest in the OECD countries. Is there any way that we can, as time goes by, identify why that might be, apart from what we've been talking about, inefficiencies, duplications, etc., which I think is part of that problem?
Yeah, it's like one of your earlier questions. There's a rather long, windy answer to try to address it.
The longest way around is often the safest way home.
Yeah, to try and address why we're not getting the results that we want. I suppose, look, you could read the Sláintecare report and would go a long way towards answering it, because that identifies the steps towards addressing it, you know, and to actually be where you can still spend the same amount of money and get so much better outcomes. But it is essentially an infrastructure that was designed that is not fit for purpose anymore, and that's, I referred to that earlier, both I suppose the design of the administrative aspect of the HSE and how it was set up initially, and also the lack of IT and lack of investment in the infrastructure over the years. You know, capacity is an issue which, you know, other countries of a similar proportion don't have. We have those severe capacity issues in our acute and in our community settings. And then again, just the whole reorientation. So I think Sláintecare is probably the best answer to your question about the reorientation back towards the community from the acute setting. And if that was done, we certainly would be getting much, much better value for our money. And we have identified a 10-year plan, as you know, in Sláintecare to do that. And I often make the point, look at how far we've come in mental health under a Vision for Change, which was a 10-year plan. I mean, back in the 60s, we had 20,000 people in long stay inpatient acute psychiatric beds. Today there are less than 1,000. So we have made very, very significant reform towards community-led services in mental health, and I have no doubt we can do the same in physical health if we apply the same vigour to it over that 10-year period and embrace lawn to care, come what may, from whatever politician is occupying whatever chair of office at that time.
Thank you very much, Minister. So, Minister, that concludes our consideration of the supplementary estimate for vote 238. In accordance with Standing Order 90, a message to the effect will be sent to the Clerk of the Dáil. So, Minister, I'd like to thank you and your officials for coming in this morning and giving us your time. This select committee is now adjourned sine die.